Hello everyone, my name is Erin Cornley and today I'll be discussing ethical issues with medical cannabis in healthcare. Medical cannabis involves a wide range of ethical problems, but today I will be focusing on role fidelity, autonomy, advocacy, beneficence, and non-maleficence. I chose this topic because of the recent evolution of cannabis within the medical profession, as well as the state of Delaware and our country as a whole. The history of medical cannabis in the United States is a complicated one. Medical cannabis first gained popularity in the 1850s and was recognized nationwide as a medical substance with therapeutic use. It was a commonly sought out treatment for a variety of illnesses, and it was widely available at pharmacies in a liquid tincture form used for oral consumption. And then, with the Marijuana Tax Act of 1937 and the laws that followed, medical cannabis became illegal all across the country. In 1970, the Controlled Substance Act was passed, which scheduled cannabis as Level 1, which means it is a substance with no accepted medical use, high abuse potential, concerns for dependence, and lack of accepted safety for use under medical supervision. Even though the Controlled Substance Act is still in place, the landscape surrounding medical marijuana has changed drastically. California was the first state to pass the Compassionate Use Act in 1966, which allowed the adult use of medical cannabis. Today, in 2023, 47 states have some sort of medical cannabis or low THC program. One ethical concern with the legalization of medical cannabis is maintaining role fidelity. For healthcare providers, this includes upholding ethical principles, keeping a professional, fiduciary, trusting relationship with our patients, and remaining competent within the field. Physicians, as well as nurses, must be aware of new therapies in order to provide patients with optimal choices and new plans of care. Did you know that 85% of doctors do not even touch on the subject of medical cannabis in school, even with the discovery of the endocannabinoid system, which is a huge player in maintaining homeostasis in the human body. Currently, federal law and regulations leave clinicians with the inability to conduct research on a large scale, making research of cannabis and its chemical compounds CBD and THC underdeveloped and very, very unthorough. Without enough evidence to fully support or deny its efficacy, healthcare providers are faced with an ethical dilemma of whether or not they are able to prescribe or even just recommend medical marijuana in good faith. When discussing ethical issues and medical cannabis within the healthcare system, autonomy and advocacy go hand in hand. Advocacy is the right to choose, or also known as self-determination. There are times where traditional forms of treatment are exhausted and it leaves patients looking for alternative options. This is especially true in the treatment of chronic pain with opioids. There has been an overprescribing of addictive painkillers that have various side effects. Now, more and more patients are looking for cannabis to control their pain. Whether or not physicians recommend it, they need to put aside their personal biases so that a patient's right to choose is not ignored, allowing them to collaborate and create a care plan aligned with their own values. Advocating for a patient's right to access medical marijuana has been extremely difficult in previous years. Nurses and doctors have found themselves facing an ethical dilemma when deciding whether or not to advocate for medical cannabis to be used by their patients, with many worried that they may lose respect among their colleagues or even face legal discipline. In 2021, the American Nurses Association has advocated for the removal of marijuana from Schedule 1 to Schedule 2. A change of scheduling would permit for more large-scale clinical trials and studies, allowing clinicians to be able to understand its benefits and risks more thoroughly. Also, in 2023, the ANA acknowledged cannabis as a legitimate nursing specialty, noting their significant role in providing patient-centered care and education to a very diverse population in need. The recognition from a major medical association creates the ability for nurses to advocate more properly. The ethical principle of beneficence, or to do good, is sometimes challenging when recommending medical cannabis. If there is a treatment that could be beneficial, it should be explored. The only conditions for which medical cannabis has a strong evidence base should be recommended for palliative care, such as conditions of epilepsy, chronic pain, or chemo-induced nausea and vomiting. Now providers can do so a little bit more confidently with FDA-approved drugs such as the THC-based Marinol for nausea and vomiting or the CBD-based Epidiolex for seizure control. Physicians have a responsibility to protect their patients as well as society, so the principle of non-maleficence, to do no harm, must be practiced. Other forms of medical cannabis, such as edible or smokable routes, may be ethically difficult to recommend due to lack of proper monitoring and improper dosing, causing elevated risks for adverse health effects. Patients with cardiac and respiratory illnesses must be strongly discouraged from medical cannabis use. Medical marijuana can also induce severe psychological effects to all age groups, but it can be especially detrimental to children. Access should remain controlled, and education should always remain at the forefront when discussing cannabis with patients and their families. Thank you for listening to my presentation, and I will leave you with 2 questions. So, taking inventory of personal bias, do you believe medical cannabis should be more widely accessible to patients? Why or why not? And second, how would you suggest keeping medical marijuana better regulated to avoid commercialization and lessening youth exposure?